Most pulses patients benefit from epinephrine. Many would never achieve ROSC without it, but there appears to be a subset of patients, particularly those with recurrent ventricular arrhythmias, in whom the ongoing sympathetic surge may become part of what's perpetuating the storm. So if we like the alpha effects of epinephrine, but the beta effects can be problematic, could a beta blocker be helpful?
Hey there, I'm your host, Sarah Lorenzini, a rapid response nurse and educator who loves telling stories to teach critical thinking. This podcast is for nurses who want the knowledge, skills, and confidence to respond to any emergency. With almost 20 years of experience in the ER and critical care nursing, and a master's degree in nursing education, I have a lot of stories to share, and I love to nerd out and break down the pathophysiology, pharmacology, and nurses' role in emergencies. Stories bring learning to life. It is way easier to learn from and remember the stories that my colleagues and mentors have told me than anything I've read in a textbook. And that is why I made this podcast. Every episode is packed full of exactly what you need to know to handle whatever crisis that could arise on your shift. It's one thing to get the right answer on the test, but knowing how to detect when your patient is declining and what to do when your patient is crashing is what will make or break your day and might just save your patient's life.
Let's dive into part 2 of Breaking the Storm. If you haven't already listened to my last episode on refractory ventricular arrhythmias, you want to check that out first. We talked about the science of defibrillation and how dual or double sequential defibrillation might help in these cases where traditional single vector defibrillation just isn't cutting it. But if you did already listen to part 1, let me catch you up where we left off. My patient was in refractory ventricular fibrillation. 4 standard shocks hadn't worked. We had switched to double sequential fibrillation. And on the very next rhythm check, boom, organized rhythm and ROSC. I distinctly remember looking around the room thinking, no way that actually worked. Because up until that point, I had only ever read about DSD, and here I was witnessing it work like in real life on my patient. Everybody in the room kind of relaxed a little bit. We were already thinking about the next steps and stabilizing him to get him off to the cath lab. And then, darn it, back in ventricular fibrillation. We had a couple more DSDs and a couple ROSC. I mean, this went on for like 30 minutes. A handful of ROSC moments that didn't last more than a few minutes each. Last week we talked about the difference between refractory and recurrent ventricular fibrillation. Refractory V-fib means the shock didn't work. The myocardium remained in ventricular fibrillation despite defibrillation attempts. So maybe the current isn't getting where it needs to go. Maybe changing vectors or reducing the transthoracic impedance can improve that myocardial capture. And that's exactly why we spent an entire episode talking about pad placement and vector change and double sequential defibrillation. But recurrent VF is different. The issue we're facing now is the shocks work. The myocardium depolarizes, and for a brief moment, normal conduction won. And then the chaos came right back. So we need to start asking, why does this heart keep choosing chaos? And yes, there are the H's and T's that we need to consider for patients in PEA. Those absolutely apply here too. Hypovolemia, hypoxia, hydrogen ion acidosis, hypoglycemia, hypokalemia, hyperkalemia, hypothermia, tension pneumothorax, cardiac tamponade, toxins, thrombosis like PE or MI. And our patient likely did have some sort of thrombosis based on his history. But what if some of the meds that we're giving, epinephrine, might actually be contributing to the sympathetic surge that could add to the unstable environment of the myocardium? I'm sure you've heard me talk before about the sympathetic nervous system and how it feels when your body recognizes danger and dumps endogenous epinephrine into your body to help you manage the emergency. The classic example is how your body would respond should you encounter a bear. Your adrenal glands would dump enormous amounts of epinephrine and norepinephrine into your bloodstream. Your heart rate increases, your blood pressure rises, your pupils dilate, blood is diverted away from your skin and digestive tract towards your brain and skeletal muscles. Like every physiologic system shifts into survival mode. Now, imagine the body experiences something even more threatening than a bear, like a heart attack. By the time we arrive, the patient has already experienced a massive endogenous catecholamine surge, particularly if the arrest was precipitated by acute ischemia or another high-stress event. The body activates the sympathetic nervous system, and every pathway designed to preserve life is firing on all cylinders and pumping out that epinephrine and norepinephrine. The problem is, those same catecholamines are kind of a double-edged sword. They absolutely help maintain coronary perfusion pressure. They will improve vascular tone. They will make successful resuscitation more likely. But they also make the myocardial cells a little more irritable. Catecholamines increase intracellular calcium. They increase automaticity. They shorten refractory periods. They also increase myocardial oxygen consumption at a time when the heart is already profoundly ischemic. They make surviving myocardial cells much more likely to fire spontaneously. So if you think back to last week's episode, that's exactly the environment where ventricular arrhythmias thrive. Now, let's add to that some exogenous epinephrine in the way of IV push epi that we give every 3 to 5 minutes during resuscitation. We give so much epinephrine, and it might be making it worse for our patient. Now, before anybody clips that sentence out of context and tries to say that Sarah said epinephrine's bad, let me be crystal clear. I am not saying epinephrine is wrong. I'm not saying ACLS is wrong. Far from it. Epinephrine remains recommended by the AHA because it consistently improves ROSC. By stimulating alpha-1 receptors, it causes peripheral vasoconstriction, raising aortic diastolic pressure, and improving coronary perfusion during chest compressions. So simply put, it helps us push blood into the coronary arteries during CPR. Without adequate coronary perfusion pressure, successful defibrillation becomes much less likely. The physiology is well established, and that's why it keeps showing up in the AHA resuscitation guidelines. But here's where things get interesting. The alpha effects of epinephrine are what we want. Yes, squeeze those blood vessels. The beta effects, well, they kind of help and they kind of hurt. Beta 1 stimulation increases heart rate, contractility, myocardial oxygen demand, and myocardial excitability. So during normal circulation, that can be beneficial. But during ventricular storm, when the myocardium is already electrically unstable, those same effects may become part of the problem. So on one hand, you're improving coronary perfusion and giving the heart a better chance to survive. And on the other hand, you're pouring gasoline onto an electrical fire. And that's one of the reasons refractory and recurrent ventricular fibrillation are so incredibly difficult to treat. We're trying to balance two competing physiologic priorities at the same time. So here's another analogy for you to help wrap your head around it. Epinephrine's like espresso. Love it, but it sure has some side effects. Now, imagine trying to calm down a friend having a full-on panic attack while also handing them another double shot of espresso. You're helping, but you're also making them just a little bit more wired and a little bit more prone to anxiety. And to be fair, yes, that's probably an oversimplification. The reality is much more nuanced than that. Most patients benefit from epinephrine. Many patients would never achieve ROSC without it. But there appears to be a subset of patients, particularly those with recurrent ventricular arrhythmias, in whom the ongoing sympathetic surge may become part of what's perpetuating the storm. So, if we like the alpha effects, but the beta effects can be problematic, could a beta blocker be helpful? Now that I've piqued your interest, I would be remiss if I talked about beta blockers, specifically esmolol. That's not even in the ACLS algorithm without first talking about two antiarrhythmics that are recommended in the ACLS guidelines. Because if you have a patient in ventricular fibrillation or pulseless ventricular tachycardia, these medications should absolutely be on your radar long before you start reaching for beta blockers. So let's start discussing the two antiarrhythmic queens, Amiodarone and lidocaine. Which one is better? And if they're both considered first-line agents, why do so many of us spend years believing Amiodarone was the obvious first choice? Well, like a lot of things in medicine, the answer depends on what year we went to nursing or medical school. So when I first learned ACLS, amiodarone was the new shiny kid on the block. It had largely replaced lidocaine in the guidelines, and honestly, it felt like we finally had a better antiarrhythmic. Less side effects, but packed with the same antiarrhythmic punch. I mean, lidocaine was still around, but it felt like the backup quarterback. If amiodarone wasn't available or not working, then sure, yeah, maybe give lidocaine. But medicine has a funny way of humbling us. The more research we do, the more we realize that the things we were absolutely convinced about sometimes weren't actually true. So here's what we know now. Both drugs are ventricular antiarrhythmics, but they calm the myocardium in very different ways. Lidocaine is actually a simpler drug to understand. It's a class 1B sodium channel blocker. It primarily works on ischemic ventricular tissue, exactly the tissue that's causing us problems during an acute myocardial infarction. By blocking those fast sodium channels, lidocaine decreases ventricular automaticity and suppresses those irritable ventricle cells that keep trying to fire before they're supposed to. I've always thought of lidocaine like the teacher who walks into the noisy classroom and doesn't yell at everybody. She just walks right over to the one table that's causing the trouble and says, "You guys, enough." Lidocaine's very targeted. Amiodarone, on the other hand, it's like the dean that's just yelling at everybody to be quiet. It blocks potassium channels, sodium channels, calcium channels, and even has some alpha and beta blocking properties. It prolongs the action potential, lengthens the refractory period, slows conduction, and decreases automaticity. It's pretty pharmacologically complicated, but basically amiodarone tells the entire myocardium to settle down. So, if amiodarone affects all these different ion channels, why isn't it clearly better? Well, back in 1999, a study called the ARREST trial compared amiodarone with placebo in patients with shock-resistant ventricular fibrillation in the pre-hospital environment. The investigators found that patients receiving amiodarone were significantly more likely to survive to hospital admission. Notice what I didn't say. Hospital admission, not hospital discharge. Not neurologically intact survival, just admission. Now, granted, no one will ever make it to hospital discharge if they don't first make it to hospital admission. But a couple years later, the ALIVE trial compared amiodarone directly with lidocaine. Again, amiodarone looked better. But once again, the primary endpoint was survival to hospital admission and not survival home with your family. Now, these two studies were enormously influential. They were part of the reason why amiodarone became the preferred antiarrhythmic in ACLS for many years. And honestly, based on the evidence we had at the time, that was a reasonable decision. But then came one of the largest cardiac arrest drug trials ever performed, the ROC-ALPS trial. Now, this study randomized more than 3,000 patients with out-of-hospital shock-refractory V-fib or pulseless VTAC to receive either amiodarone, lidocaine, or a placebo. And everyone expected there to be a clear winner, but there wasn't. Overall survival to hospital discharge was not significantly different between the three groups. Wait, hold up. No difference between the three groups? Not amio, lido, or the placebo? None of them improved survival to discharge? Yes, you heard me right. The largest study we've ever done comparing these medications found no statistically significant difference in overall survival. Survival to hospital discharge was 24.4% for amiodarone, 23.7% for lidocaine, and 21% for placebo. Now, before we throw all the antiarrhythmics out of our crash cards, let's look a little closer. This study looked at out-of-hospital arrest, and among patients who arrested that were witnessed, both amiodarone and lidocaine appeared to improve survival compared to placebo. The benefit seemed greatest when EMS arrived quickly and the myocardium hadn't been ischemic for an extended period of time. That actually makes physiologic sense. Antiarrhythmics will never fix dead myocardium. They do stabilize the viable myocardium, however. The sooner it's given, the more healthy myocardium remains to be rescued. So, does the ROC-ALPS trial prove that the drugs don't work? Not necessarily. It tells us that just neither drug is the miracle. Neither one replaces electricity. They're both just adjuncts. They make successful defibrillation more likely, but they don't replace defibrillation. That is an important point because people often imagine amiodarone or lidocaine like chemically converting ventricular fibrillation the way, say, adenosine might convert SVT. That's not what's happening. In cardiac arrest, these drugs are rarely the hero. They stabilize the myocardium just enough so the next defibrillation attempt has a better chance of successfully depolarizing enough myocardium to restore organized electrical activity. Electricity is still doing the heavy lifting here. And perhaps most importantly, the ROC-ALPS trial found no meaningful difference between amiodarone and lidocaine themselves. But remember, the study was powered for survival, not neurologic outcome. So, despite what I see in practice, amiodarone isn't listed above lidocaine anymore in the ACLS algorithm. They are peers. The AHA isn't saying these drugs are identical. They're saying that the current evidence doesn't support one consistently outperforming the other drug, and it's a reasonable option to give either one for V-fib or VTAC. So both therapies perform similarly, and clinicians can choose based on experience, availability, contraindications, or patient-specific physiology which one they want to give. Sometimes lidocaine might look better, say a patient who has like an elongated QT segment prior to the arrest. And other times, amio might look better because, say, the patient has like a structural heart disease. But neither will ever trump defibrillation. They are just supporting actors for defibrillation, which has been and should always be the star of the resuscitation show. So, though I was raised as a nurse in the era of amiodarone is magic, I've actually always thought lidocaine was easier to administer. Amio has this like weird viscosity. It's kind of bubbly. If you've ever drawn it up, you know what I'm talking about. If you put too much air in the vial or you agitate it just a little bit too much, you will draw out pure foam. Additionally, the dose for pulses patients is 300 milligrams. You have to draw up 2 separate vials. And to do it right, without the bubbles, this takes time and finesse. So contrast that with the ease of lidocaine administration in a code. Most crash carts have the pre-filled Lorjet syringe boxes of lidocaine. It's the pink and white box. You might have never actually administered it because so many clinicians default to amiodarone, but it's way easier to pop the tops and screw together the lidocaine than having to delicately handle the amiodarone and puncture the 2 separate vials for your amiodarone dose. The only downside of lidocaine administration is the dosing requires a tad bit of math. While the dose of amio is set, 300 milligrams for pulses arrhythmias and 150 milligrams for arrhythmias with a pulse, lidocaine is weight-based. The initial dose is 1 to 1.5 milligrams per kilogram, and you may give additional doses of 0.5 to 0.75 milligrams if needed. So for your average size patient, you'll give a whole syringe with just 100 milligrams, or maybe a half a syringe if you have a tiny, frail adult. Maybe a box and a half if you have a large adult, but even then, I think lidocaine is easier. Needless to say, since they are equally recommended, I've started to say to the doc, it's time for an antiarrhythmic. Do you want to give 1 or 1.5 milligrams per kilogram of lidocaine, or do you prefer amiodarone? Just to remind them that it is an option. But in reality, to be honest, I don't care either way. I just want to do something to promote successful defibrillation and cardioversion to a rhythm that can actually generate a pulse. And both med options are recommended. Now back to my patient. We were well into this resuscitation. We had already done all the things the guidelines recommended. We had shocked him. We had excellent CPR. We'd given amiodarone, both doses. We'd given lidocaine, both doses. We had corrected reversible causes as best we could. We had literally emptied the entire top drawer of the crash cart. Yet every few minutes, he kept diving right back into ventricular fibrillation. And at this point, we were doing kitchen sink medicine, like just throwing everything we can, hoping that something might work. We were also giving the recommended dose of epinephrine, 1 milligram every 3 to 5 minutes. At this point, it was like 10 milligrams of epinephrine. Like, could we be making it worse? Okay, now that I have covered amiodarone and lidocaine, I think we can talk about esmolol. Now, you all know I'm a resuscitation nerd, and I read resuscitation literature for fun in my spare time. There's a study I read from 2014 that compared 6 patients who got esmolol after usual ACLS care with 19 who just got usual ACLS, epi, shocks, antiarrhythmics. All 6 patients who got the esmolol achieved ROSC with survival to discharge with a good neurologic outcome was like 50% in the esmolol group versus 11% in the control group, the ones with no esmolol. Now, this is a very small study, yes, and the results were still impressive. There's another single-center retrospective study in 2016 that compared 16 patients who got esmolol to 25 patients who didn't in refractory V-fib. And they had similar findings with improved ROSC and survival to hospital discharge in the esmolol group. But whose idea was it to give a medication that lowers blood pressure to patients who basically have no blood pressure? Okay, so esmolol targets a different problem than amiodarone or lidocaine. I don't want you to think that I'm comparing these pharmacological interventions. Antiarrhythmics work by suppressing ventricular arrhythmias, but beta blockers, we would be giving them a code to blunt the massive catecholamine surge that can keep ischemic myocardium electrically unstable. So by selectively blocking beta-1 receptors, esmolol reduces myocardial oxygen demand, decreases automaticity, and may help break that vicious cycle of recurrent or refractory ventricular fibrillation, allowing defibrillation to be more successful. We're trying to create a calmer environment for the heart in full freak-out mode so it's able to respond more favorably to defibrillation. But why esmolol and not one of the many other beta blockers, you ask? Well, simply, it works fast and it wears off fast, so you don't have to worry about the med lingering in the system after you get ROSC. So back to my patient. After a couple of ROSC episodes that didn't last long enough for us to even load him up and get him off to the cath lab, I suggested another intervention that's outside of the ACLS algorithm to my physician colleague. Hey, doc, what do you think about trying esmolol? He said, I don't even know the recommended dose for refractory V-fib, but sure. So while our pharmacist went to grab the esmolol from the pharmacy because it's not stocked in the crash cart or in the pre-post cath lab area, I went to find the article because I surely didn't know the dose either. So I pulled it up on my phone and I showed the doctor. It's 0.5 milligram per kilogram bolus. So I was kind of envisioning like a vial of esmolol, but the pharmacist brought me a bag of esmolol, and it was 2,500 milligrams per a 250 ml bag. And I was like, oh, shoot, that's a lot of math. But it actually comes out to a simple 10 milligram per ml, which is the same as the vial. Fortunately, our patient was about 100 kilograms, so it was easy enough math, even for me. But I still checked with the pharmacist to make sure that 5 milliliters was the correct volume before I administered it to our coding patient. And you know what? It worked too. We held epinephrine for the next round. We gave 50 milligrams of esmolol instead. And after the esmolol had circulated for a bit, we gave another shock and we got ROSC. And it even lasted long enough to get him off to the cath lab. Now, to be fair, I actually don't know if it was the esmolol, the cumulative bath of antiarrhythmics, dual sequential defibrillation, or just time that finally worked for my patient. But I can say that shortly after administering esmolol, we were finally able to achieve sustained ROSC. Now, we are 2 for 2 for thinking beyond the algorithm, and I'm trying to keep my enthusiasm under wraps because I have work to do. But me and the doc, I can tell from his face, we were just in awe. Coincidentally, me and the same doctor had another refractory V-fib code and CAT scan like 2 weeks later. And in that second case, we transitioned to DSD and added esmolol much sooner, and we got ROSC right there in CAT scan. Crazy. Evidence-based practice is awesome. Okay, so that day, I walked away with 2 lessons that I will never forget. The first is that electricity matters, but how we deliver electricity matters too. For more on that, please check out episode 164. I dive into much deeper detail. The second is that not every patient fits neatly inside the algorithm. Sometimes the heart keeps choosing chaos because the physiology underneath is still chaotic. And I'm not satisfied with just memorizing the next drug in the algorithm. I want to understand why I'm giving it and be able to combine what I know about the physiology and the pharmacology and what the evidence says to be able to critically think to provide the best care for my patient. That is critical care at its finest, using my knowledge to think critically to care for another human in need. So here are 3 things that I hope you remember the next time you're standing in front of a room with a patient in recurrent ventricular fibrillation. First, every successful shock is giving information. The rhythm terminates and then comes back. Think physiology, not just electricity. Second, remember that antiarrhythmics are just the adjuncts. They don't replace high-quality CPR and defibrillation. They increase the chances that your next shock will actually be successful. And third, don't stop thinking just because you've memorized the ACLS algorithm. The algorithm is the foundation, not your ceiling. Keep asking why. Keep reading, keep learning, keep collaborating with the whole interdisciplinary team. That is how we can offer our patients the best chance of survival and hopefully a neurologically intact survival, because saving lives is truly a team sport. Whether you're a nurse or a doctor, a paramedic, a pharmacist, a respiratory therapist, or an EMT, we all play a role on this team, and I will forever be working to level up my knowledge and my skill set for how I care for the sick. I'd love to hear from you. What are your thoughts about giving lidocaine instead of amiodarone? Have you seen recurrent V-fib that just won't stay gone? Have you ever used esmolol or another strategy outside of this standard algorithm? So come find me on Instagram, send me a message. These are the exact kinds of conversations that I think make us all better clinicians. Thanks so much for listening. See you next time.
Before you go, I have an exciting announcement. You can now earn CEs for listening to this podcast. That's right. Renegade has teamed up with podcast hosts like me who are delivering amazing content that not only educates, but inspires you to be the best for your patients. You get to learn and earn continuing education credits while absorbing knowledge from thought leaders and innovators in the field of health and medicine. You're already listening to podcasts during your commute, at the gym, or while unwinding after a long day. So why not earn your CEs at the same time? And that's where pod classes come in. Yep, it's just what it sounds like. It's CE learning through podcast. To learn more, I put a link in the show notes for you. Well, thanks for listening. I hope you learned something that will save a life. Remember, nursing is a team sport, so trust your intuition and don't give up advocating until you are confident you've done what's right by your patient. The views and opinions expressed on this show are that of Sarah Lorenzini's. That's me and mine alone. They are not intended as medical advice and should not take the place of your institution's policies or procedures. Evidence-based practice is ever-changing, and your patient care should reflect the current best practice. So if you want to get in contact with me, you can shoot me an email at sarah@rapidresponsern.com or on all social media platforms as the Rapid Response RN.